Good evening to all of you. I'm the last man standing. Just like there is, I should first of all thank Academic Ophthal Forum for having done this great job. I was there last year and the year before that also. I can only see that they are growing year after year and it's becoming far more responsed and with so many people around. It's really a great job they're doing. They should keep it up. So just like how you have the neuronal loss, you have the neuronal loss which happens with age. I think we have been seeing audience loss from morning till evening, which is understandable given the nice quality of baked rasgullas what we had. So since this is the last talk, though this is supposed to be scientific, but I thought if I'm too scientific, I'm going to bore you people. I'll try to keep it a bit philosophical. I also thought it's going to be more appropriate if I do that, since this being the last talk of the day. So what I'm going to do is I'm going to present a few cases. These are going to be examples of how glaucoma behaves, the weird kind of different presentations it can have, how do we approach, and what are the lessons we learn from each of the patients. I always think that glaucoma is something like a fingerprint of a person. So how each fingerprint is unique to each of us, similarly, glaucoma of each and every patient is different. So if we are going to take one common method by which we are going to treat all the glaucoma patients, you can be sure that we are going to be wrong. So the treatment has to be individualized, and that is also the enigma of glaucoma and beauty of glaucoma at the same time. So the four cardinal principles on which I'm going to talk, this is not going to be in exactly the same order, it is going to be mixed. So the four important things will be making the correct diagnosis, setting a target IOP, initiating the proper therapy, and having a proper follow-up. I'm going to give some examples on this. Let me start with a 60-year-old male, Mr. Arnab Goswami. He's very, very active. He has a pressure of 18 millimeter mercury and 15 millimeter mercury in right and left eye, with the anti-segments being normal and open angles, and a CD ratio of 0.5 and 0.4. So this is a very simple thing I'm going to start with. Now, when you see the intraocular pressure, and then you just see that the cup is not very, very huge. Here it's a very small cup. It's not very big, 0.7, 0.8. In the common practice that we do in a busy practice in ophthalmology OPD, we don't have the tendency of doing a dilated examination to all the patients, especially above 40-year-old. My suggestion is, even if there is a slightest doubt, or even if there is no doubt, all patients above 40 years of age should undergo a dilated examination. Only when you do a dilated examination will you be able to pick up a RNFL defect as subtle as this. You can see that this RNFL defect is extremely subtle. With the undilated examination, you're surely going to miss such a situation. So my first caution and my first principle and my first message, kindly be sure you do dilated examination in all these patients. A 90 or a 70D examination and a red-free examination for beginners when there is a doubt, or for everybody. In case you don't do it, if it is the real Arnab Goswami, he is just going to question you. Nation wants to know why you did not dilate. Be careful about that. Not only you need to be medico-legally correct, but you need to be clinically correct as well. I'm going forward with the same patient. A visual field was done. The left eye was normal. However, the eye with the 0.5 cup in the right eye with the RNFL loss superiorly showed a very minor arcuate scotoma just in the beginning stages. Now, what do you do here? There are some tests you should add up. You cannot say you're going to make the diagnosis only here and finish off with it. It is true, you got the diagnosis in your hand, you have an arcuate scotoma which is matching with the RNFL. But fine. However, if you get a RNFL analysis, a disc photograph, serial drawings, and pachymetry, all of these are just going to add up to the information that you have. Okay, we have done the RNFL analysis. What does it show? It matches up with the right eye where we had an inferior RNFL loss, But in addition, it also shows that there is a very small RNFL loss, which was not seen so clearly on the disc photograph as well on the clinical examination as well, or it was not at all seen on the visual fields. So these are the small things which we pick up when we go into a more detailed examination. In this case, now what are you going to do further? Are we still missing something else? Yes. Let us see if we do a diurnal phasing, what happens. So this was the IOP which was measured in the beginning. I said it's about 15 or 16 millimeter mercury. Only when we go diurnal and then see those early morning readings here, do you realize that the IOPs are really shooting up, and he is one of those morning risers of intraocular pressure. Had you not done the diurnal phasing in this patient, you wouldn't have categorized this patient as POAG and simply put it as NTG, or maybe even ignored the patient in the worst possible scenario. So make sure as a principal you have all the possible tools of diagnosis utilized wherever possible. Fortunately, now you do get some of those on rent also in case you don't own them. The more information we have, the stronger will be our diagnosis and decision making. The next patient I'm going to talk to you is about 45-year-old open angle glaucoma on treatment, 18 millimeter mercury, maximum medical treatment. Remember these points. He's on MMT on treatment for past 4 years. We do a visual field examination. This is over a period of 3 years. What do you see here? You can see that over a period of time, there is a minor increase which is happening slowly but steadily in the visual fields. The point I want to make here is, here we have done a GPA, glaucoma progression analysis. This plays a very, very important role in detecting cases of glaucoma progression, and this makes our task very, very easy. I'm not telling without a progression analysis you can't do the diagnosis, but what you have to do in such a situation is you have to place all the visual fields side by side and then compare them and look what is happening over a period of time. This is not going to be an easy process, a laborious process, and I am sure very few of us will actually end up doing it even if we have access to those fields. So if you have a GPA, this gives the information at a glance. Encourage patient. The second point I want to make out of this patient. See, this patient had a yearly examination of the visual fields very, very meticulously. Imagine a situation if this patient hadn't come for proper follow-up, or we had missed to advise him the visual fields, either for financial reasons or whatever else. In that case, we would have missed this serial progression and then would have missed a very, very great opportunity to take up the treatment in the early stage of the treatment. Now, how are you going to go about in such patients? When you have an assured progression, when you have a confirmed progression, consider surgical intervention or resetting the target IOP by medications, however you want, especially given the fact that this was a 45-year-old patient. Make sure it is not too late when you intervene. Let me take up this another patient as an example. You can see that he had a very small amount of defect in the superior arcade region when you see here. This patient did not come for follow-up for a long time. When he came about 4 or 5 years later, this was the status of his visual fields. These are not exceptions. Probably these are pretty much commonly happening in our daily OPD, and then we see them on a very, very common basis. These patients, we don't want it to happen. When we do the RNFL loss, there is hardly any RNFL remaining there. You can see the RNFL being far more damaged than what can be seen in the visual fields here. So you can be sure that the visual fields is going to deteriorate over a period of time even further. So here I want to stress upon one point. Importance of frequent examinations cannot be overstressed at all. It is our duty to inform the patient and make sure he understands the disease, because making sure he understands the disease is the first step in making sure that you are getting prompt number of follow-ups from the patient. If you don't talk to the patient and the relatives, you can be assured that this is going to be a very common thing in a glaucoma OPD. Second point I want to make here is, you can see that why did the patient come even 5 years later? The patient came here 5 years later because you can see that the fixation is getting involved. When the fixation gets involved, the vision drop is much, much more. Had this patient not had a fixation involved but a biarcade scotoma which was sparing the center, he would have come much later with only about 5 or 10 degree visual fields. I'm not saying this is a good situation, but I am just telling you how the patients present, and involvement of fixation is a very major point in the patient's journey with glaucoma. Of course, here the target IOP has to be tempered against the condition of the patient, and I'm not going to go into the details of how that is done. Let us go into another 55-year-old male, IOP between 16 to 21, CD ratio of 0.5 in both the eyes, no family history of glaucoma. You can see that this is the visual field of the patient. This is over a period of 3 years, the latest being just last week. I think probably this 2025 last week. You can see that hardly any change is happening in the visual fields. It's almost like more or less like a normal visual field in the right eye. This is the comparison what I am putting also in the left eye of the same patient. In fact, the visual fields are anything but improving over a period of time, if you would want to say that. Of course, there will be a lot of learning curve involved. Now comes the interesting part. I'm going to put we are not going to stop here. So many a times we do have this tendency that if we have a suspicion, we do the visual fields. If the visual fields turns out normal, we just forsake the patient and tell them to turn up after a year or two. And many a times, we don't warn them and they may not even come back. However, a very simple thing like a meticulous disc examination will completely change the matters and create a turnaround in such situations. This is the same patient. You can see that there is a very wide wedge-shaped defect over here in the right eye, as well as a small defect you can see in the left eye. In fact, these defects can be easily missed, but these defects cannot be missed. If you miss it, it's a grave, mistake that we will be doing with that. This is the RNFL red-free photograph of the same patient. We took the RNFL analysis of the same patient. Without any doubt, you can see the same things being accentuated even on the RNFL map also. So here, the point that I want to make out of this example is, you cannot trust on only one modality. Since visual fields, I understand, is the most commonly available modality of testing, it's not necessary that that is the best one. Sometimes a simple RNFL analysis just through a red-free can throw up many, many more clues and indications of how you should be managing the patient than just depending on the machinery that are available. I'm not undercounting the machinery use here. I'm not telling OCT is useless or visual fields are useless. What I'm saying is, solving glaucoma and understanding glaucoma is like solving a murder mystery. The more information you have, the more clues you have, the more effectively you will be able to diagnose the glaucoma, and the diagnosis should be wholesome. The other point I want to make you is, trust your eyes and the disc photographs more than anything else. And the pre-perimetric glaucoma, keep in mind, be cautious to make a proper diagnosis here. Don't be over-enthusiastic in making a pre-perimetric diagnosis, but at the same time, be careful not to miss out the subtle clues that these can provide it to you. The same patient, when we did, this is the last thing for this patient, we did the corneal pachymetry. We find out that the patient has a slightly thinner cornea. So here you add up about 2-3 millimeter mercury. So the IOP, which was 21 millimeter mercury, suddenly comes to about 24 millimeter mercury, and he's a POAG patient. And also diurnal would be required. So now this is another patient where this is the right eye of the patient. You can see that the disc and the RNFL appear pretty much normal, whereas this is the left eye of the same patient, where you can see a small wedge-shaped defect in the inferior area. I'm sorry about the poor quality. This is a comparison between 2024 and this is 2025. So you can see that the subtle RNFL loss probably has increased. I'm sorry about the bad quality photograph which was taken recently here, but you can probably make it out a little bit better here. I can see it better in the laptop here. So there is a slight subtle widening of the RNFL over here. You can see it much better when I'm doing the same comparison on the OCT. So OCT in the left eye, you can see that the right eye is normal. When we come to the left eye, you can see a slight widening of the wedge over here. So when we see the visual fields of this patient, this is the right eye of the same patient, which was normal. Now I'm coming to the left eye to see the visual field, what happened in this 1 year. I'm going to put this is 2024, this is 2025 of the right eye. This is 2024 and 25 of the left eye. You can see the amount of change in the visual field which has happened. Though there was an increase in the RNFL loss over a period of time, this was just 1 year, mind you. In this 1 year, the change in the decibels in the visual field is enormous. This is a very huge amount of loss, almost about 3 decibel loss in the visual field happening in 1 year. This makes him a very, very fast progressor. Being the fact that he's only 55-year-old is going to put him in jeopardy in the next few years. So here comes the graph, the whom to treat graph. So here you need to categorize the patients into who are fast progressors and who are slow progressors. The fast progressors with young age need to be really looked and paid a lot of importance to. So I'm just going through very quickly, run through 4 or 5 small examples here. All of them are serial analysis, all the next 4 or 5 patients. Very quickly, I'm going to run through and give you some small take-home points and some philosophical messages out of these patients that you're going to see. This is a 52, this is the serial analysis I have run is on my Octopus. I could accommodate 10 serial analysis. I do have some of them are much more in these concerned patients, but I can put 10 maximum serial analysis in one shot, and that's why there are about 10 here. He's a 52-year-old techie with a good control of intraocular pressures. He's a very meticulous patient coming for visual fields every 6 months, sits in my chamber and gets his IOP checkup. He's been doing this for the past 18 years without fail, and I see him on a regular basis. If you have good follow-up of the patient, this can do wonders no matter even an advanced glaucoma like this. I've had ups and downs with this patient. I haven't put the older fields which I had from 2012 and all that, where he had progression happening. I had to intervene and do surgery, and this is what you're seeing is after surgery and a good follow-up. I want to use this scenario to stress how important the follow-up is, and if you have good follow-up, the truth is you can catch hold of glaucomas around 80 to 85% of the situations and make sure they're stable. This is an 85-year-old or multimillionaire with a very active lifestyle. He developed Parkinson's and Alzheimer's in 2019, but you can see the kind of progression which is happening here. It is a very severe progression which is happening in a very acute stage. Now, till here, I had a follow-up of quite a few years with him before, and it used to be quite stable. But suddenly it started progressing. In situations like this, where the progression is happening very fast, you have to take difficult situations. He's 85-year-old, he's developed Parkinson's, he's developed Alzheimer's. Be very practical. Normally, you would need to advise surgery in such patients, but in patients like this, unfortunately, you can't do it and keep them on medical line of treatment as long as they survive. This is a software company owner. I live in an area in Bangalore, which is probably the tech zone of Bangalore, and probably about 60% of the software that happens in India comes from the area within 3 kilometers of where I live. So my Intel head office, the Google head office, all the head office, the Microsoft R&D is all beside me. Most of my patients are IT engineers. This is a software company owner at 82 years. Probably there is a slow deterioration happening over a period of time, both in the right eye and in the left eye. So since he is already 82, he is on maximum medical treatment, but it is still acceptable because the amount of deterioration that is happening is quite acceptable. We don't need to advise him surgery. And we know that, even he is still healthy, this kind of a speed should serve him for the rest of his life. And this is another professor at Indian Institute of Management at Bangalore. He had to give up his active lifestyle because you can see the kind of deterioration what he has over a period of time. He was very active, reading almost like devouring 2 to 3 books every 1 week. He was such a voracious reader, and then he came to this. Now, the funny thing is, this patient has an intraocular pressure of 10 millimeter mercury in both the eyes. You can't do anything more than that. I have put him on citicoline. He comes every time and says, you want to try anything on me, you just try. And I have actually done it and tried almost everything that's available. Despite that, there is a progression. This is a bit of a reminder to us that we still are not in that level where we can control all the diseases of the human body and not even glaucoma. So this is like, shows up our place sometimes where we stand, and we still have a very long way to go. And this is probably here you can see this is a very young patient of 45-year-old, and you can see that the progression analysis is very crucial here. But at the same time, you can see a lot of fluctuation happening in the left eye visual field over here. Be careful, don't react to each and every small visual field changes that happen on the visual field, because a lot of times, these could be event changes which happen. This is a 40-year-old cardiologist whom I have seen. There is no visual field change at all. He had an intraocular pressure of about 35. His father lost his eye due to glaucoma. He was my patient. His brother has glaucoma with a very high intraocular pressure. This is a strong family hereditary glaucoma. In such cases, I didn't wait. No visual field changes. I did cataract surgery. I did glaucoma surgery for him, and he has been doing well till November. In November, he developed viral conjunctivitis. I just want to bring up one point that was talked about netarsudil and in failing glaucoma. So this patient, what happened in November is when he developed viral conjunctivitis, the bleb got inflamed very badly because the conjunctivitis was quite bad. This inflamed bleb caused a bleb failure in the young patient who is a cardiologist. Now, this similar thing can happen even with ripasudil. When you use ripasudil in failing glaucoma, you are causing congestion of the bleb and redness of the eye. This can cause failing of the bleb even further, probably a word of action over here. So right now, just about last week, I did bleb needling for him, and his pressures have come back to about 10, 12 when I last saw him day before yesterday. And this is the last slide, I promise you. So this is a 30-year-old techie with ocular hypertension since 10 years. He's been having a baseline IOP of 30 millimeter mercury and on timolol PG combination. So the point I want to drive here is that you should be, even though the pressures can sometimes be quite high, don't panic in cases of ocular hypertension. Be very calm. See how you are going to treat the patient. If you have the data over so many years of period in ocular hypertensive, even if it is a 30 millimeter mercury also, you can be confident nothing is happening over a period of time. So be careful. And the treatment of the patient involves a lot of modalities and just not one or two things. To summarize, get your diagnosis right, set, maintain, and rechange target IOP as required, and look out and treat progression. We have a lot to do in glaucoma, a lot of work to be done, but then we have had also a lot of successes over a period of time, and we are able to maintain our glaucoma patients far better than what we used to do about 30 or 40 years back. Thank you so much.
Thank you, Dr. Shirish. Thank you so much. I think this is the last presentation of the session. If you have any questions from anyone in the audience, any delegates? No? I'll request Sumit sir to please give a memento on behalf of all of us to Dr. Shirish. Can someone please take the pictures? Yeah. We have some mementos to be distributed. Okay. Yes, please.